Dr. Murphy is professor of blood transfusion medicine at the University of Oxford and consultant hematologist in the NHS blood and transplant hospitals, the Oxford University hospitals. And a lot of us know him as a speaker, and we're looking forward to hear his presentation. Dr. Murphy.
Thank you very much for inviting me. Can you hear me okay?
No. You have to turn on.
Okay,
That's it.
fine. Can you hear me now?
Yes.
Excellent, okay. Well, Dr. Maniatis, thank you very much for inviting me. It's a real pleasure to be in this beautiful part of Greece. I've been doubly fortunate, actually, because one of our ex-trainees in Oxford is now working in Salonika, and she has given me fantastic hospitality and shown me around the local area, which I didn't know. So thank you, Despina, very much for looking after me, and I will definitely be coming back. So I'm going to talk about safety of blood transfusion. There has been huge progress, as you know, in the safety of blood transfusion over the last few decades, particularly in the safety of the blood that's provided to hospitals. There's also been an improvement in the safety of transfusion within hospitals. But unfortunately, there are still terrible events like this, where blood collected for a patient was given to another patient with a very similar name. There was a mix-up resulting in an ABO incompatible red cell transfusion, and the patient died. So this is understandable mistake, but clearly it's unacceptable and it shouldn't happen. So are these events still happening now? So this slide shows data from the FDA in the United States, where they collect information on mortality and report them each year, so 2005 through to 2010. So you can see in 2010 there were 2 deaths from ABO incompatible red cell transfusion. So these events are less common. They're less common now than other important complications of transfusion like TRALI and TACO, but these events are still happening. What about data from the UK? So we have a national haemovigilance system called SHOT, Serious Hazards of Transfusion, and they've been collecting data on transfusion, adverse events to transfusion since 1996. So the top of the columns are the number of wrong blood transfusions, incorrect blood transfusions, and the bottom part of the column are the number of ABO incompatible red cell transfusions. And you can see that the number of the ABO incompatible red cell transfusions has gradually been reducing. There were only 4 in 2010. But they're still happening, and I'm told that the SHOT report for this year, which will come out fairly soon, has again found cases of ABO incompatible red cell transfusion. So these mistakes resulting in wrong patient care don't just occur in blood transfusion, they occur in other areas, so wrong drug administration, wrong side surgery. Since the 1980s, there have been at least 13 reported incidents of where patients have either died or been severely disabled because they've been injected intrathecally with vincristine rather than methotrexate. One of these incidents was investigated by an individual experienced in investigating rail disasters and other types of major incidents. And it was this poor boy here who died because of an intrathecal injection of vincristine. And what he found was that there were 40 areas of failure in this one incident, resulting in this boy's death. And the death didn't just occur to human error alone, but human error in a weak system. And there were lots of other problems with safety culture, with lack of good procedures and protocols, poor communication between staff, poor presentation of the drug. And this same investigator went on then to investigate other healthcare incidents, including a very high-profile error involving in vitro fertilization, and he found similar problems. So experience with investigating and dealing with incidents outside healthcare, like in aviation, has found that to make improvements, it's necessary to understand the causes of the incident and then correcting them, not just telling people that they must take more care the next time. And usually there's no single cause for the breakdown in safety, but multiple factors, including human factors. And an investigator called James Reason suggested that we should think about these things in a different way, in a systematic way, and recognize that humans are fallible and make mistakes. And he suggested that for an error to occur, there needed to be a successive breakdown in the defenses preventing errors. And if there were a number of errors in the defenses that lined up, then that would result in something terrible happening. And the defenses that could be thought of, or the holes in the defenses could be thought of as just simple mistakes or staff not doing the procedure properly, or there might be holes in the defenses because of faulty equipment or lack of staff training. And I think that's quite helpful when we think about investigating an ABO red cell transfusion, for example, of trying to work out what is wrong and what needs to be done to prevent them again. So, coming back to transfusion now and thinking about the transfusion process, which involves multiple different steps, from assessing the patient's need, informing the patient and getting consent, thinking about what blood product is needed and the amount, ordering it, taking a blood sample for compatibility testing, delivering the blood, and then checking the identity of the patient before the administration of blood, and so on. And there are many people involved in this process: doctors, nurses, phlebotomists, laboratory staff, and so on. So the complexity of this procedure means that it's perhaps not surprising that errors occur. So thinking about the defenses to avoid errors, and they can be thought of as the people involved, and you may have special people involved, like transfusion safety officers or transfusion nurses, specialist practitioners, who would carry out the training of the staff carrying out the various processes in transfusion, the very procedures themselves, the SOPs in the laboratory, the standards by which these procedures are carried out, and monitoring practice, and then thinking to now and the future, thinking about using technology to make it easier for the staff to carry out these procedures correctly. So those are the defenses. and they're used to a different degree in different hospitals and different countries. And different hospitals and different countries have implemented these additional specific measures for transfusion. So in some hospitals, they send out staff from the blood transfusion laboratory or the blood bank to train the ward staff and to look at their practice, to watch them carrying out a transfusion and checking that they're doing that correctly. And the term auditing into compliance has been used where that is done a lot, that every day there are staff going out from the transfusion laboratory. In some European countries, there is bedside ABO grouping in addition to compatibility testing. In some hospitals, they'll use an additional numbering system as safety. In Oxford, a number of years ago, we used a red label, which was a number allocated at the time of the sample being collected for compatibility testing. An additional wristband would be put on the patient. The number would be put onto the blood sample, and that number would follow the process round. It would be put on the blood bag at the time after the blood had been cross-matched, and then the number would be checked at the bedside before the blood was given to make sure that it was the same. Very similar is the blood lock system, where a number would be put on a wristband of the patient, and when the blood bank had cross-matched the blood, it would be locked in a plastic bag with a lock which could only be opened with a number on the patient's wristband. And then there are automated systems for bedside matching, and that's what I'm going to tell you about shortly. Okay, so that's really an introduction to this talk. I'm going to tell you about how we approach this problem in Oxford. And we had a vision of using technology to improve transfusion safety, but also to make it easier for the staff to do the process right and reduce the complexity of the procedure. And also to try and use technology to help us reduce blood use and blood wastage. As you know, there are new European regulations about tracing blood right to the patient, not just to the time that it leaves the transfusion laboratory, but right to the patient, and regulations about training staff. And so we thought that technology could help us deal with those, and also to help us make blood available for patients when they need it really quickly, particularly in hospitals without their own blood bank. So that was our vision. I think we're on the way to achieving most of those now, but as always, there are new things to do. So this slide is to show you, take you through the process, and the key thing is to have a printed wristband on the patient with a barcode on it. I was having lunch today in town, and even the napkin that I was given had a barcode on it. We think we have barcodes everywhere now in supermarkets, and everything for retail. You know, why can't we have a barcode to help us identify patients? So this is a linear barcode that will just code at one number. Better are these more complicated dotty barcodes that you see more now. Well, that will encode for us the patient's first name, surname, date of birth, gender, and their identity number. And we have the patient's details also eye-readable so that they can be read. So the main equipment at the bedside is a handheld, is just a little scanner which will take the nurse through the process, and I'll show you that in a little bit more detail in a minute. But it also will scan the barcode, and when the sample is being taken for compatibility testing, we can attach this to a little bedside printer and print out a label to go on the sample tube. So this is a printed label, and again it has the barcode with the patient's details on it. So when that gets to the laboratory will scan the patient's details into the laboratory system, and then the laboratory carry out the grouping, antibody screening, and when they're identifying a blood unit for the patient, they print out a little label which has the patient's details, eye-readable, the blood bag details, eye-readable, and in this red box there's a barcode again which has the patient identification details, but it also has encoded in there is the unit number of the blood bag. So at the bedside, when the blood is going to be administered, the nurse will be taken through the process, which I'll show you on the next slides. She'll scan the barcode to get the patient's details, scan that barcode to make sure that the patient's details match. There'll be an alert if they don't match. And also the alert will go back to the transfusion laboratory, and then they scan the unit number here to make sure that the laboratory have put the right label on the right bag, and then the blood's administered. We also have an electronic system for collecting blood. So again, the handheld will be used to print off a little label with the patient's details on. This is a little computer by the blood fridge, which controls access to the blood fridge. So scan in the patient's details, and the blood fridge opens, and the unit of blood is scanned to make sure that it's the right one for the patient. Also, and this fridge is even more complicated. This fridge will just deliver the right unit. With this fridge, there's a drawer for each ABO and rhesus D group, so APOS, OPOS, and so on. With this, so you take the drawer, only the drawer with the patient's group will open with this fridge. But with this one, it will deliver the right unit of blood for the patient. So like a Coke machine, which is the vision. We also identify the staff. So the staff on their hospital identity badge will have a barcode. So whenever they carry out any part of the process, whether they're collecting a blood sample, administering blood, or collecting blood, first thing they do is to identify themselves. Okay. So I'm just going to take you through the process a little bit. So on the handheld, you can do various things. You can check to see whether there's blood available for the patient. You can order blood. You can collect a blood sample, print off this pickup slip so you can go and collect blood, and you can transfuse, or you can view reports, or you can carry out training. So we're going to do this. So the transfuse part of it, so you can check the arrival of blood on the ward. You can do begin transfusion, which is what we're going to do now. You can record vital signs of the patient too, and you can end the transfusion, and you can go through a rapid procedure for an emergency transfusion where you can check a number of units, say units of red cells, fresh frozen plasma, and platelets, all in one go. So the first thing is to scan your own identification, as I've explained, scan the patient's identification, and then scan the compatibility label on the blood, and then the label on what the blood service have put on to make sure that everything matches. Can also provide some prompts for the nurses. So should the patient be having CMV negative or irradiated blood? do some other prompts. So have you checked the patient's blood group? Have you checked the expiry date of the blood? We can record vital signs before, during, and at the end of the transfusion. So temperature, respiration, and then having done this is for the pre-administration checks, you can print off a little label which can go in the patient's medical record. So the staff like it, the nurses like it. It's one nurse rather than two. It takes them half the time to do that process, and they like it because they know they're getting it right. We, as part of the introduction of the transfusion system throughout all our hospitals in Oxford, this was going back 10 years now, we persuaded the hospital to put in a wireless system. And that helps us because we can download all the information from the handheld back into the transfusion laboratory. And we're just in the process now of making the ordering system, the ordering process for blood, more intuitive for the doctors, and to provide them with the information like the latest blood count, and to also tell them if they're ordering an elective red cell transfusion for a patient and the hemoglobin level is too high, say for a top-up for an orthopedic patient, we can send back a message to say that it's too high and they should think again. So that will help us reduce inappropriate use of blood, hopefully. So devising this sort of process is all very well. You need to show that it's effective. Ideally, the best way of showing that it was effective would be to demonstrate that the number of wrong transfusions was reduced. But there are so few of those that that's really not an option. So the way that we chose was to demonstrate that the procedure was carried out correctly. And we needed to carry out some baseline measurements, and when we introduced the system into the main haematology ward in Oxford, we carried out some observations of the practice before we introduced the system. And we observed the nurses to check whether they were carrying out the very basic checks, the really key identification checks correctly. And we found that they were carrying these out correctly on very few occasions. And actually, it's not only us that have observed that. I've taken part in international studies where we've observed nurses carrying out bedside check before transfusion, and they've carried these out, less than a third of the time they've carried these out correctly. We wanted to see whether we could, before we introduced the electronic system, whether if we train the nurses very hard, we could get them to do the key checks better. So we trained them very hard for a month, and we did have some improvement, but we were unsure. It certainly wasn't where we wanted to be, and we were unsure how long that effect would last for. But when we introduced the electronic system, we got to where we wanted to. As I've said, the electronic system records all the information taken at the time of the transfusion, and this information is available in the blood bank. So we have information like where the transfusion was. This was in the adult ICU. This is the patient's information details here, so I blanked those out. So this is the blood unit. This is when it was going to expire. This is when the transfusion was. These are the patient's details matching up on the wristband and on the blood bag, and all the vital signs are here. So the traceability of blood, which we have to do now with all the new regulations, is all done electronically. We don't have to have a manual paper trail and having the laboratory staff chasing up the ward staff to make sure that it all happens. It's all done electronically. And actually, in the laboratory, they have a live view of all the transfusions going on in all the Oxford hospitals. So again, I blanked out the patient's details here. These are the different blood units, the type of product. So this is an FFP. So this transfusion is underway in one of the operating theatres. And you can see that actually with these three transfusions, the initial observations during the transfusion haven't been done. So the observations are done before the transfusion. The observations and the nurses can't start the transfusion without doing those. The observations during and at the end of the transfusion, we can't force the nurses to do those with this equipment. But we can monitor those, and I'll show you what we do with those in a minute. So we went through various pilots of using this system in hematology, cardiac surgery, critical care, and by 2006 we were ready to implement the system through all the Oxford hospitals, and we did that over 18 months. It was a lot of training, a lot of hard work, a lot of monitoring was important. So what was actually going on. So we were monitoring the use of the electronic system for sample collection. So this is now 2011, and you can see that the electronic system is used for nearly all the transfusion, for all the sample collection, and almost all the transfusions. It's above 99% most of the time. We know where the electronic system isn't used, and we follow these up. We send somebody out from the laboratory or our transfusion practitioner to follow these up and to find out why the system isn't being used. Is it the person hasn't been trained properly? Was the equipment not working? And we'll fix that. We can also monitor the practice of every member of staff and feed back the information to them. So, for example, this is the information from one of our nurses. So during this period, she carried out 32 transfusions. She only carried out the initial post-transfusion observations in 12 of those, so she's one of those who's not carrying out the 15-minute observations, so we'll feed that back. She's also not confirming that the transfusion ends in every case, 28 out of 32, so she needs to be reminded about that. We've got the information about the e-learning that she's doing with transfusion, and that's up to date, which is great. So we feed back this information to the staff and their managers, their senior staff, to help them improve their practice. Now, the other thing that I mentioned earlier on that we were keen to do was to make sure that patients receive blood quickly if they really needed it, particularly in some of our distant hospitals, because in Oxford we have a centralised transfusion service. So we have one laboratory for multiple hospitals, and in fact one of the other hospitals in Oxford, which is 2 or 3 miles away, does all the haematology and cancer care, most of the elective surgery. And so it's a challenge to make sure that when things go wrong, say with a surgical patient, that blood is available quickly. Now, we do electronic issue as standard. I guess that many of you do the same. So we group the patients and antibody screen them. The antibody screen is negative. We don't do a formal cross-match. We just issue the blood. And that means that it is provided very quickly. So we've taken that one step forward, particularly for the hospital on the remote site, where this query can be carried out at one of the computers by the fridge. So if the patient is, we know their group, we know their antibody screen is negative. So blood which hasn't been previously allocated to any patient can be allocated to that patient, provided that they fulfill the basic criteria. So group known, antibody screen, negative. And we can print off a compatibility label at the fridge, put it on the blood and taken away. So that saves any transport of blood across our city. So other centres now providing a centralised transfusion service, including in the United States, are now using this system. And I mean, we find that running a centralised transfusion service is really helpful to us in running an efficient service, just having one main blood bank for our area. Okay, so having explained the system that we use, what are the benefits? We've had the system fully implemented for over 5 years now. That's over 125,000 units of red cells. So we've had no ABO-incompatible red cell transfusions. We could say that, well, maybe we wouldn't have expected to have had one because the incidence of an ABO-incompatible red cell transfusion in the UK is only about 1 in 150,000 units. But we've had no serious wrong blood events. We've reduced the wrong blood in tube and the number of samples that we reject from the blood bank hugely with the electronic system and the printed labels. The only problems that we have now are with the very few which are taken manually with writing on the sample tube, but we're reducing those. We have the compliance with the blood traceability, with the training and competency assessment of staff. We have lower wastage, and we've reduced blood usage. Not just using this system, we've done lots of other things to reduce blood usage, and unfortunately I haven't got time to talk about those just now. That's really a whole another talk. What about the cost? So you're probably thinking, well, this must cost an absolute fortune. But we have similar constraints in trying to identify monies, funding for new developments like this. So it costs us now about £400,000 a year to use this system. And we use about 35,000 units of blood a year, so it costs us about an additional £11 a unit. But there are savings. As I've said, there's a lot of saving in nursing time. There's some saving in time in the laboratory. There's also the reduced blood wastage, and also a contribution, I think, to the reduction in blood usage that we have. And actually, if you think of some of the other transfusion safety measures that have been introduced in the last 20 or 30 years in terms of blood testing, which obviously really important, but actually the cost of this compares quite well to that, I think. So what else have we done? We've written a specification for this electronic transfusion system for the UK. We were asked to write up this system as a recommended intervention for hospitals in the UK to do transfusion better, and we provided all the information about costs that I've just shown you, so the hospitals knew how much those costs were. And we've recently, well, about a year ago, we had a look to see how other hospitals in the UK were using electronic systems. And actually there's been a big increase in the blood tracking systems, so that's the electronic blood collection from the fridges. So nearly half the hospitals now are using that system, but many fewer are using the bedside system. I mean, this is definitely harder to implement because of the staff training and maintaining the equipment out on all the clinical areas where blood is used. But anyway, there is progress here. And we've tried to publicise what we're doing, and we've entered competitions, and we've won some prizes. And I use this slide to show the team that have implemented the system, and this is many people. So this is Julie Staves, who runs our blood bank. These are some of the nurses that have worked out in the clinical areas to implement the system. They're now doing other things like intraoperative cell salvage and near-patient hemostasis testing as we try and get a handle on reducing blood use. This is one of the ladies who works in the electronic patient record system. This is a biochemist colleague of mine who's interested in informatics, and we had a partnership with a small commercial company who have now been taken over by a large commercial company. And this was a finance manager. It was very important for us to work closely with the finance manager, particularly at the time when we wanted to implement the system fully. Thank you very much.